Great. Welcome, everybody, to the Heroin Task Force Quarterly Community Partners Meeting. I'm going to go ahead and start the slideshow. And John, I'm going to let you welcome everybody in.
Sure thing. Good morning or good afternoon, everyone. John Kettler. I'm with Waukesha County's Department of Health and Human Services, and I'm grateful to be able to welcome everyone today to the quarterly Heroin Task Force Community Providers Meeting. It's a great working group we have. If anybody's new with us today, our Heroin Task Force meets quarterly, and there are also four work groups, action groups that are working and meeting individually around once a month. Feel free to get involved with those, express interest to us, and we can connect you with whichever group you're interested in working with. So we just want to thank everyone for taking the time today to join us and to make this a priority. And I think we've got a lot of really great stuff on the agenda today. So let's jump in.
Fantastic. Thanks, John, for a warm welcome. Nicole Bry, if you would drop your email into the chat, that would be awesome. So Nicole is our admin support for the Heroin Task Force. And if you have any questions, you can direct them her way and she will make sure to funnel them to the right place. I also invite you to check out our Waukesha County Heroin Task Force website. We're keeping that up to date as well. So feel free to share that link with others as well. So I am going to just a couple of little housekeeping things. I think we're all pretty good at this by this point, but just in case, I know we're all working on different platforms. I actually hop between 3 different platforms these days, but you have a mute button and we'll ask you to stay muted just to keep those outside noises from getting into our meeting. Please share your video if you can. We'd love to see you. There's the chat. You guys are already actively using the chat, so we're good to go there. And I invite you also to use the reaction button as well. So if you see something, hear something that you'd like to react to, we wanted to invite you to do that as well. Thank you, Rachel. That's exactly it. Just some of our virtual meeting guidelines. This hasn't changed since we've been doing this the last year or two. We really encourage you to use the hand raise feature if you'd like to invite your voice into the conversation. We talked about staying on mute. Be fully present, but take care of your needs, obviously. Be mindful of your airtime. We're going to have some small breakout rooms after our presenters, so be mindful of your airtime so you can share that opportunity with your breakout room mates. And when you're done with a thought, say I'm complete, so we know you're done and we can move on to the next person. So those are the guidelines we've been working with. So our goals for today, every time we meet, and John, you set the foundation beautifully for us. We want to continue to grow our community partners network. We want to continue to do this great work together. We know it isn't going to be just one person or one group that's going to make it happen. We are fighting the opioid crisis together as a community, and that's what we're here for. We're going to hear from our action teams and really encourage you to step in or lean into those teams if you are interested. We'll hear more about those a little bit later. And then today, our focus is on stigma reduction and awareness. We are really blessed to have Rachel Cooper, who was a past Heroin Task Force member and is now a current back to us Heroin Task Force member. We are so glad. She works for Rachel, I'm going to let you do your introduction when we get to you. But she works for a national organization. She is the director for stigma. So we are so glad to have her. You all took, or many of you took, a survey, and that is going to be a lot of our conversation today. I'm going to invite you. Rachel's the first part of the meeting, but the second half of the meeting is unpacking and reflecting on what we heard. And I really would encourage you to stay. A lot of times people back off on those small breakout room conversations, but that's where the juice is. And we're hoping to take the information that Rachel has provided us and our conversation and turn this into action for us as a team and then for us individually as well. So we'll invite you into that space as well. You all have the agenda, so I'm going to hop over that. And I also this is a big topic. Rachel Cooper, Colleen Allen, and I have been in contact for quite some time now to get ready for today. This is a big topic, and There's a lot to it, and there's a lot to it personally as well as we're reflecting. So I want you all to just take a breath and step into this room, look at these intentions. You don't have to call them out, but think about how you want to step into this space today and how you want to receive this information, as well as how we want to interact with this information. So I'm just going to give you a second. These are just some thoughts. What intention do you want to hold for yourself today during this conversation? So just a breath and take a minute. And thank you for that. I'm actually, before we invite our county executive into the conversation, I'm going to invite John Kettler back to the microphone here. We've got a couple of things that we wanted to share with you.
Oh, thanks, Terry. Yeah, I just wanted to share a couple things. And the first is to acknowledge the International Overdose Awareness Day Candlelight Vigil event. Really strong work from the Support Recovery Action Team. It was an amazing event. Just wanted to shout out to Mary Simon for helping secure the park, Susie Austin for leading the event, and the whole team for putting the event together. It was truly powerful. Went till about 9 o'clock that night. Big impact on the families, talking about loss of loved ones. You can see a few pictures of the luminaries here before the sun went down. So the event went from about 6 till 9. It was an amazing event. And I got to say that this really reminds me of why we're coming together as the Heroin Task Force. All the work that we're doing outside of these meetings as well. Some of you may be familiar with the lecturer Simon Sinek. And he talks about knowing the why behind what you do. If you're interested, you could Google his TED Talk on the subject. He gives a larger one, but there's a condensed version as a TED Talk. Maybe we'll drop it in the chat. It's powerful. It talks about the why, why you do. Get in touch with the why you do what you do. And this visual really reminded me of why, we do this and why we need to keep our foot on the pedal right now. We've done a lot and there's a lot more to do. So, I also wanted to take a moment to help us remember our why by sharing a recent news piece that was put out on TMJ4, and it helps us remember our why. This is a piece that was done as part of the Overdose Awareness Day coverage. It involves our county's Women's Health and Recovery Project, WARP. A number of you have been involved with WARP. We have Charlie Hart, I believe, with us in the meeting here today, who is one of the folks in the video. And I just wanted to share this. It's short, but I think it really speaks to the why we do this. So if we could just take a moment to watch this, it just speaks to it. And Terry, if you'd be so kind, would you roll the story?
I am going to do my very best. It's about a 2-minute video, so give me just 1 second
Sure
here.
thing. Thank you.
It's 6:47 right now, and from hopeless to hopeful. On Overdose Awareness Day, our Sarah McGrew shares the story of a Waukesha woman who beat the odds to still be here today and is now in recovery, sharing her story.
I've had a lot of overdoses with alcohol and with other drugs. Honestly, I shouldn't be here, to tell you the truth.
Megan McWilliams has been in and out of treatment in the legal system for more than 2 decades.
Like a revolving door.
But today, she's celebrating 9 months sober.
It's been a very long road, and nothing has really worked for me until I got into this program.
That program is Waukesha County's Women's Health and Recovery Project, or WARP. The program helps support and connect women with everything from addiction treatment to housing and food pantries and even dentists.
Women that come through the doors can be anywhere from still using and contemplating getting clean and not knowing how to navigate that path, to women that are in a couple years of recovery.
Charlie provides peer support at WARP, including for Megan.
Megan has a special place in my heart.
And I think the biggest thing from the beginning that she gave me was hope. And I was totally hopeless.
Some people said that, she was just going to stay the way that she is, and I took that personally as a challenge to make sure that I was going to be by her side and help her through those struggles.
Their bond in recovery is undeniable.
I mean, I still have days where it's difficult, but it's so much better than it was that I don't want to go back.
Now, on the other side of several overdoses, Megan and Charlie hope others will find the courage to ask for help before they even reach that point.
It might not be pretty and it's going to be hard, but it's so worth it in the end.
There is hope. There is definitely a life on the other side, and we are here to help in that.
We have more information on WARP and how you can start your recovery there at tmj4.com. Reporting in Waukesha, Sarah McGrew, TMJ4 News.
Thank you, Terry. That was amazing. And Megan will be graduating from the alcohol treatment court, OWI treatment court now, in 1 week. And it goes to show there's many systems of care that have helped this person, and it speaks to all the work that we're doing. And it just helps me remember why we're doing this, why we devote our time, why it's important to push back on stigma, because anyone can recover. Anyone can get into recovery. So, we wanted to share this and just keep in mind as we work today on and moving forward, why we're doing this and that we are having a great impact. The Heroin Task Force is doing great work, and wanted to share, just that the county also has a robust response to the opiate epidemic as well. So what I'd like to do is introduce County Executive Paul Farrow. Paul's been a leader on many of these responses, and I want to give him a shout out actually for engineering a team to pull together a dashboard for local data. It's not easy to get local data, and it's something we've kind of run up against for some years. And Paul energized us to make that happen and got the right people to the table. So now it exists. So thanks for that. So why don't I bounce the ball to County Exec Farrow? Can you tell us some more about the county's response?
Hey, John, and thanks for the kind introduction. Hey, I didn't do anything. All I did is empower my team to do what they do best, and that is get the job done. When you look at the dashboard that they created, the information that's out there, I know the state's interested in what we've done. They didn't think this could happen. Well, once again, Waukesha County, we proved that it can happen. And you can put the right people in the room together and say, you guys, go for it. It's amazing what they can come up with. But that's just one piece of the puzzle. And when you think about what we've been doing this last year since we created the community health crisis around fentanyl last August, we've had some great successes. The OAK kits that we're putting out throughout the community, I think by the end of this year, we're going to have over 200 kits that are out there. We're looking at other opportunities using some information that's already accessible. There's an app called Pulse, which gives people locations for AED devices. And actually, if you are an individual who knows CPR, you can log on to this and say, hey, I'm here. It will ping you where you are. So if you're in the area where there's a cardiac issue, it might say, are you willing to be able to run over and help this person out? We're hoping to be able to piggyback Narcan onto that, so that if people see a situation occur, they're going to know they can reach out and find the Narcan, hopefully in the same area where the AED devices are, and work our way through. You think about reducing the stigma around a number of different areas. That's, I think, the biggest thing that we've been trying to overcome and get people to realize that Narcan isn't an enabler. It isn't another drug. It is a second chance in life. And it's an opportunity to get people, for a lack of a better term, a wake-up call to say, hey, we have people here that are willing to help you and reach out to you and give you that second chance, like Megan, that can get through 9 months of recovery. That's really what this is all about, and trying to reduce that stigma as much as possible. I think when I look back this past year, the different events that I've been to, and if you guys want me at any of your events, please feel free to reach out to the office. I mean, this is an area that is near and dear to me to make sure we get the message out. Knock on wood, I can say that in my family, I haven't had to deal with this. I have friends who have, and I want to make sure that we're bringing as many of our resources together in order to get people to realize there's help out there, there's opportunities that we can work with you, whatever your position is on the path that you're going through. And I look at the Twist and Shout for Recovery that SOFA did earlier this year out with the Dock Hounds. We had almost 3,000 people in the stadium. John, you were out there with the team from Public Health. We had individuals picking up Narcan kits as they were walking out, getting more information. We actually aired the first of its kind, John, as we said. We trained almost 2,000 people on how to use Narcan with a 2-minute video that we got from the state. And I think it opened a lot of people's eyes to understanding what it is and what we can do and how we can approach this to get people to realize this isn't, as I said before, an enabler. This is an opportunity to give us a second chance and give those we love and care about a second chance. So we're going to continue to do that. I do want to give another shout out to the Rockwells and the Love Logan Foundation. Relatively new, they put together a golf outing and they maxed it out at 144 golfers. Talking to individuals at that event opened people's eyes to realize that, especially fentanyl and the opioid epidemic that we're facing, isn't one group of individuals. It's across all sectors and everybody's impacted at it. And we need to work together to get the information out, to get the understanding out, and help people see that there's alternatives that are out there. So we're going to continue to fight where we can. I'm going to continue to empower my team over at HHS, who does such a wonderful job for us in this. And again, I want to thank you all for what you do. As you know, together, we're making a huge difference. I think back in prior to COVID, when we first started doing the training for Narcan back in 2017, we were starting to see a reduction in overdoses. Fortunately, with COVID, it started coming back. Good news is it looks like we're starting to catch up to it again and starting to peel back some of the issues that are there and getting people realize there's help that's there. There's opportunities for us to work together. So I thank you all for what you do on a daily basis to make a difference in Waukesha County, and wherever we can from the county, we're going to partner with you to keep being successful.
Great. Thank you so much. We are greatly appreciative for these updates. We're glad to have you join us. Stick around if you'd like to hear the presentation. Otherwise, we are recording it. We can get it to you. So we appreciate it. All right. We are ready to move on to our guest speaker. So Rachel, I hope you're ready to go there. My friend Rachel is stuck in an airport, but she's ready to go. And Rachel, would you like me to share the screen, or you think you can do it?
You can go ahead and do
I'm
it.
happy.
It might just be easier
Yeah.
in the event of shenanigans.
Yep, happy to do it. So Rachel Cooper is the Senior Director for the National Stigma Initiative. And you're out of Washington, D.C., if I'm correct?
Well, right now I'm at Dulles, but normally I'm in Madison, Wisconsin.
Right. So she is a Madison resident. She's been on our team before. So I'm just going to turn it right over to you to introduce yourself, and I'll get your slides ready to go.
Awesome. Thanks. Yeah. So thanks, Terry. Thanks, John. Thanks, Paul. Thanks, everyone. And it's good to see some familiar faces. So like Terry alluded to, I was part of this task force a number of years ago in the harm reduction space, working at what was then the AIDS Resource Center of Wisconsin, now Vivant Health. And yeah, I'm excited to be back as part of a national organization that's really focusing on stigma reduction in large part. So Terry will be able to also send out the slides after we go through, so I'm not going to spend a ton of time on the initial ones. I know that she's pulling them up now, but in brief, and I think we can probably go straight to slide 2, Terry, probably 3. I think slide 3 would be great. Yeah, just kind of looking at what we're going to talk about today is we're going to talk a little bit about Shatterproof, the organization that I work for, a little bit about addiction stigma, what it is, what it isn't, how to measure it, kind of what we're seeing as far as some of the data, including data from the task force itself, and then kind of what works to reduce stigma and some of those implications and action items. So Terry, I think we're seeing the chat right now, so we can go to slide 4, and then I'll just keep going and doing our next slide thing. Awesome. So Shatterproof is a national nonprofit, right? We're dedicated to reversing the addiction crisis in the United States, and we have 3 main pillars that are on slide 5, which is looking at the treatment system, so increasing access to and quality of treatment, supporting and empowering communities, and then breaking down addiction stigmas, which is what we're here to talk about today. So, as all of you know, right, we talk about addiction stigma all the time. Like, stigma is a barrier. Stigma. What is hard is to actually know what works to actually reduce.
Hey, Rachel,
Of course, not
Rachel, we're,
an unstable internet thing. So if I drop,
yep,
yeah.
I'm wondering if you might want to just
Next
turn your video off.
slide, please,
And
Terry.
yep,
See
and
if
if you
that
want,
works.
you might want to turn your video off and see if that helps.
Yep.
Okay.
So we'll see, and if not, I'll just call in on my phone.
Yep,
Again, sorry for
perfect.
the very long delay issues today. So what we did here, and this is a perfect slide to be on, Terry, is to really look at what has worked to reduce stigma in other social change movements, right? So looking at mental health, looking at, you know, LGBTQ rights in marriage, looking at HIV/AIDS, looking at other experts in the space, what actually works to reduce stigma. So we looked at all of these things, right? And came up on the next slide, Terry, with essentially that there's 6 key success factors to like actually reducing stigma. So this is some of the stuff that the stigma action team is going to be able to leverage as well. One is that, you know, having a well-funded central actors like really benefits the creation of rapid change. You know, it reduces the recreating the wheel stuff that kind of happens. Looking specifically at key actions in education and changing language and changing policies. Yes, of course, Christine, all of these will be sent out. Education initiatives, so using contact-based strategies, a lot of us talk about. We actually just saw in the video, right, like the peer-to-peer stuff. You know, what does it look like to humanize, to use contact-based strategies? And then using, you know, the idea of like activating influential institutions. So when I think about Waukesha County, I think about a lot of the institutions that are represented on this call, right? Who can lead in this space to really achieve public adoption. Sometimes incentivizing is really critical. So both positive and negative incentives do change behavior. And then also recognizing that we have to really mobilize both in grassroots, so, you know, very ground level work, and then also what, you know, the grass quote unquote house, right? So making sure that everybody's adopting from top down and also from bottom up. As far as addiction stigma specifically on the next slide, we realize that this is it's a key driver of the overdose crisis, right? So a lot of things drive overdose. We all know this. But when we look at some of these drivers, we see that really 7 of the 9 of them are driven in part or entirely by stigma. So things like shame and social isolation, people not seeking treatment, when they do, insufficient treatment capacity. Sometimes we see non-evidence-based treatment. I know a lot of people here have experience with some of that non-evidence-based treatment stuff that's out there. Obviously, the criminalization of people with a substance use disorder. But really, at the end of the day, all of this is a social and structural barrier to recovery, right? So with the goal being to get people to a healthy place or to recovery, depending, stigma really is a major barrier here. So on the next slide, really, we have to define addiction stigma, because often all of us think about stigma in different ways. Some of us think about it in some way, some of us think about how we felt when we experienced it. So we're going to just level set here. And the next slide really is the definition that we use at Shatterproof, which is that stigma it's a mark of disgrace that's associated with a circumstance or a quality or a person. So when we think about substance use, we're thinking about people who either use substances or people with a substance use disorder. In essence, at the end of the day, it's a barrier both to receiving healthcare as well as engaging in those help-seeking behaviors, right? And it results ultimately in discrimination and exclusion. So on the next slide, I'm going to define a couple different types of stigma. And we talk about this in a few different ways. So the first is, you know, the idea of public or individual stigma. And that's really what we think about, most people think about when they think about stigma. So, you know, society's negative attitudes towards a group of people that creates an environment where people feel unwelcome or judged, shamed, blamed. It does include, you know, stigmas towards medications for opioid use disorder. From the structural stigma side, we're looking at that systems level discrimination that's like caused and codified by institutional policies or dominant social norms. And the key is here that we can't forget that we create the structures, right? So maybe we're not the people who are creating big P policy or little P policy, but we elect people, we vote, we advocate for things in our community. So what we believe, like our attitudes, our norms, our beliefs get codified into institutional policies, right? So at the end of the day, we are still responsible for not only creating policies and kind of some of us creating some of the structural stigma, but also we have, the kind of the responsibility to then reduce it as we change our own attitudes and behaviors. Lastly, we talk about self-stigma, and self-stigma really is where people kind of accept those societal stereotypes and experience the reduced self-esteem and self-efficacy. So like self-esteem here would be like blaming yourself for your substance use disorder or feeling unworthy, right? Self-efficacy is more kind of like, I don't think that I can change. So I don't think that I am able to make the changes. So therefore I'm not even going to try, right? I'm not even going to seek help. Or if I did seek help, nobody would help. So those are some examples of self-stigma. So on the next slide, I want to just talk a little bit about how like stigma actually comes to be, right? Because it doesn't just magically pop into existence. So stigma really begins with stereotyping or like creating, kind of damaging and often inaccurate beliefs. And this often occurs through like labeling and language. And I want to note here that most of us learn these stereotypes when we're like real little, right? We're like 3 or 4 years old. We listen to what people, adults, TV, whatever say around us. We learn things when we're young, right? So these stereotypes are somewhat unavoidable. And, particularly with substance use, it's really centers typically around perceptions of dangerousness, perceptions of hopelessness, the kind of that clean, dirty language. But it's important to realize that the stereotype itself isn't what really creates the marginalization. It's really at the end, it's the prejudice and then the ultimate discrimination that does. And that prejudice really occurs when a stereotype leads to fear and shame, the kind of internalized blame that I was talking about. And this really tends to lead towards disparate opportunities such as decreased access to healthcare, unavailability of employment, reduced ability to secure safe and affordable housing, all of those kind of structural discriminations that we see, but also individual level discrimination, such as not wanting somebody with a substance use disorder to be in your family, to be in your neighborhood, to be in your workplace. So if you want to just click one more time, Terry, I just wanted to note here that some of the critical examples in the substance use space really do center around competence or dangerousness. And what this drives is a desire for social distance. It derives a desire, for not being around people, right? And then really enhances those discriminatory attitudes and behaviors. So on the next slide, I wanted to just note a couple things quickly. We've kind of touched on a few of these. We've touched on kind of labeling, but to be clear, I don't have to say the words to y'all. You know the words better than I do. We're talking about words like addicts, like junkie, etc. Labeling hurts. People say like sticks and stones may break my bones, etc., etc. Like words hurt, right? We can't get away from that. But words can also help. We talked about stereotyping. We talked a little bit about the distancing and the discrimination. But that fifth key component really centers on status loss. So what status loss looks like in this case is like, I don't want somebody with a substance use disorder to be my boss at work. I don't want them to marry into my family. I don't want them to hold an elected position. So even when people in recovery, we still see the status loss, this desire to not have people with a history of substance use, even if they've been in recovery for X number of months or years, we still see a desire to not have them hold positions like that. On the next slide, I just wanted to note really quickly that there is one more thing to really kind of think about here. We've had the traditional prejudice, competence and dangerousness, looked at social distance. We looked at internal, talked a little bit about how we internalize prejudice. And there's obviously a ton of literature on this that I can provide as well later on. But the last bit here is the perceived discrimination. And what the perceived discrimination part of this is really that it's the idea that if I disclose, then there are going to be consequences of some type. And maybe I won't get the job that I'm applying for. Maybe my partner's parents won't like me. Maybe I won't be accepted to a program that I'm applying to. And the reason why this is important is because it prevents people from trying at all. And it also speaks to those broad social norms, right, that we don't even necessarily think about, right? It doesn't trickle down necessarily. So let's say we change attitudes, right? does it actually trickle down into somebody thinking that they can succeed? That is a totally different question than, do I blame myself for my substance use disorder? So there's a lot of work to be done in that perceived discrimination space. So, obviously kind of going through this pretty quickly here, obviously we're a little strapped, for time and whatnot. But I wanted to share a little this video that Carrie can play in just a second here that really talks about, it really humanizes what I'm talking about, right? So this has all been very academic so far, level setting, labeling, putting terms to ideas, to broad concepts. But in this particular instance here, if you wanted to play this video, I just wanted to share some words of somebody that that has really experienced this firsthand.
That's good. Thank you.
Words can become grenades, strategically spoken at times to do the most damage. And when those words come from family and friends, they cut deeper. Labels erased my humanity. Total strangers felt allowed to criticize or judge me, saying that I was just a drunk or addict. These words also carried the connotation that I was lazy, selfish, or criminal. After a while, I began to believe the words, concluding I no longer served a purpose or deserved hope. Luckily for me, these feelings were eventually replaced with words that provided healing.
The research is clear. Not only do words shape how we view people, but words also shape how we treat them. For example, studies show that when someone is described as an abuser or addict, the general public and even clinicians are more likely to believe that they should receive punishment over treatment. Tragically, for those with addiction who are looking to lead fulfilling lives, hearing the terms drug abuse or addict is paralyzing and demotivating. It blames people for their own illness, ignoring environmental and genetic factors. It feeds into the stigma they experience from society, their family, and treatment providers. To help decrease stigma around language, the Office of National Drug Control Policy recommends using person-first language to replace judgmental and negative terms. For example, a person with a chronic medical illness that impacts their brain is not an abuser or an addict. They are John with a substance use disorder. John, a person who requires treatment and support to recover from his illness. Words matter. They can hurt and reduce someone's motivation.
Together, let's choose supportive, non-judgmental words that lead to treating people with respect and compassion.
Thanks so much, Terry, for sharing that. I appreciate that. So I'm just on this slide right here, I just really wanted to hammer home the point essentially that stigma at the end of the day manifests as discrimination and isolation, right? Like negative perceptions of people with a substance use disorder, they're extensive, they're deep-rooted, not only among like the public, right, but among employers, healthcare professionals, friends and family, and people with a substance use disorder themselves. And this really does affect and dictate how policies are created, how care is provided, how people perceive treatment. So these feelings, these deep feelings of exclusion and shame can stick with people for years and years, through treatment into recovery and recover again, regardless of their recovery status. So which really powers this cycle that we're all here because we care about and because we're working to end. But it does make substance use disorder much more difficult to address and does really fuel negative outcomes. So the next bit that we're going to talk about here is talking about a tool that we have called the Shatterproof Addiction Stigma Index, which was created in large part because we realized, well, how the hell do you actually measure stigma reduction, right? It's one thing to throw a billboard up or to do a PSA on the radio or to do some sort of education intervention, right? And it's one thing to measure knowledge change. It's easier to measure knowledge change. We can look at pre and post. Somebody learned something, right? We know what we want people to learn. It's another thing to measure attitudinal change, and measuring attitudinal change can be really complicated. So the tool that, very briefly, and for those of you who are data nerds, there's much more information to be had on this that I'm more than happy to send over. But on the next slide, it goes over really briefly that what we decided to do was really create a measurement tool to assess attitudes about substance use and people who use substances from the public, right? It measures perceptions of people with an SUD as well. So we were able to look at self-stigma. We oversampled for healthcare professionals to get a deep dive into what healthcare professional addiction stigma looks like. And it's a national survey, right? So we were able to use some of these validated stigma measures to really benchmark levels of addiction stigma across the country. On the next slide, just some brief stuff methodologically speaking. We use these things called indexes or indices, which means that we're able to look broadly speaking at public stigma, structural stigma, and self-stigma, not simply as disparate, discrete data points, but as an umbrella, right? So measuring change in this kind of composite manner lets us set a baseline. It enables us to measure in a comprehensive way progress, in terms of, well, honestly, both increasing and decreasing addiction stigma. And we were also able to use what we call the vignette strategy, which starts, and for those of you who were able to take the survey, you read this, which says, you're going to read a brief description about a person, let's call him John. You're going to read the description of him, answer some questions about how you think and feel. No right or wrong answers, right? And then what this vignette goes on to do is to use the DSM-5 diagnostic criteria for a substance use disorder. And why we use this vignette strategy is because it for four real reasons here, right? One is that we have a neutral tone here. We're not saying addiction. We're not saying substance use disorder. We're not immediately provoking a bias by using some of those kind of like hot words, right? We're also looking at what a real substance use disorder profile looks like. So really eliciting reactions based on like actual symptoms of a substance use disorder. We also are able to, this way kind of look like we're not labeling, we're not saying, again, the word addiction. We're not saying anything that's like, again, going to predispose somebody to believe or think one way or the other. We're actually looking at the behaviors that somebody would exhibit with a substance use disorder that is diagnosable. And then because we're doing all of these things, it really replicates how a person, just a random person out in the general public, would interact with somebody with substance use disorder. So it's a really cool tool that you guys kind of got a brief look into. And it looks at these different scales, right? So it looks at public stigma, structural stigma, stigma against MOUD, self-stigma, but then also we were able to look at some of those other subscales, including one about harm reduction, which we're going to talk about in just a second here. So the things that we learn from this is we learn kind of like these things that sit into this public stigma thing on the next slide, Terry, this slide, perfect, is we look at kind of diagnostic labeling. So what is John experiencing? Is he experiencing illness? Is he experiencing a mental health crisis? Is he, what is it caused by? Is it caused by genetics? Is it caused by a lack of willpower? Is it caused by something else? We look at desire for social distance. So what level of proximity is acceptable? Is acceptable to happen in your workplace, in your family, in your neighborhood? And then what do we believe about him as a person, right? Do we believe that he's competent or dangerous or trustworthy or not? So these are the kinds of things that we're actually able to learn. And part of the reason why we utilize this tool today is because, for this meeting today is because we can actually look at, some of the stuff that we have inside this particular group of people, because we all have our thoughts and feelings, our own lived experience, both possibly as a person with a substance use disorder, as somebody who works in the field, as somebody who has a family member, etc. What do we actually believe? What do we have? Where do we have to start within ourselves to create, long lasting change? So some quick notes on the national data on the next slide, Terry. I just wanted to this is just some quick stuff so you can kind of pull this in your brain as we're talking about the task force specific data. We're looking at less than 1/4 of respondents really viewing substance use disorder as a chronic disease. Now, this can be both positive and negative, right? Sometimes people interpret the word chronic to mean like not treatable, right? And the last thing we want is for people to believe that this is not a treatable condition. But we still see, after this is some 20 years of SAMHSA and the CDC and everybody really pushing the definition of a substance use disorder as a chronic relapsing brain disease, a lot of people aren't believing that still. We still see that some half of respondents hold beliefs that substance use disorder is caused by bad character or a lack of moral strength. And in the social distancing sphere, that a lot of people are not willing to live next door to or be close personal friends with somebody with a substance use disorder. And this third bullet here is a place where I tend to spend a lot of time mentally, and that we do live near people who have a substance use disorder, and we are close personal friends. We just maybe don't know it. So when we think a little bit about what this really means, it talks a lot about, to me, about exclusion, in on a exclusion that we're not conscious that we're doing, right? What have we said? What have we done? What attitudes have we expressed? to people who are already in our lives? What doors has that closed, and how can we reopen them again? Lastly, on this slide, stigma does persist even when a person is in long-term recovery. And what that looks like here is that even when somebody's in recovery, people don't want that person as a supervisor at work or to marry into their family. So, from the idea of like, what does that do? I mean, we think a lot about like asking people to share their lived experience. We think a lot about asking people to share their story. And even when people are in recovery, that's not necessarily like a mentally safe thing to do unless we can provide a safe space for that to happen. People are still scared to share. And how can we blame them when we know that, 50+% of people don't want somebody in recovery marrying into their family? And then what does that mean for the work that we're doing? Where do we go from here? So that's the last bullet here is just that MOUD is often viewed as something substituting one addiction for another. But generally speaking, that fourth bullet point is one that is really important for me when I'm thinking about it. On the next slide, I know that there's been a lot of interest. I know we had some questions submitted specifically on harm reduction. So I did want to point out a couple of things, which is that we see roughly 2/3 of people are willing to purchase or obtain naloxone, which is solid. And then actually in terms of safe consumption sites or safe injection sites, we see some 43% of people think that there should be one in their community, which to me, I was actually shocked at how high that was. For those of us who have been in the harm reduction space for a long time, safe consumption sites are really controversial. So I was certainly surprised, pleasantly surprised, but definitely surprised to see that. And then, fentanyl testing shift, we're seeing almost 2/3 of people thinking that they should be free and available as well. So again, this is still the national data. We'll get into the Waukesha stuff in momentarily, but I know that there was a lot of questions came in that were very specific about harm reduction and the stigmas therein. So I wanted to make sure that I shared that with you. So going to go to that next slide here, Terry, and I just wanted to, this is the part where this is kind of what we did. And, looking at kind of at what the task force believes. So, we're sitting here and looking at the respondents, right? And again, all of this data will be available later in detail, but we're looking at like some 6% of respondents thinking that bad character and moral strength played a role here. Now, I want to contrast that to the national data, which was over half of respondents felt that way. So what I'm seeing here very strongly is the people in this room, in this space, who think about this all the time, do not feel the same way as the general public. In fact, they feel it's always a dramatic change, right? We're seeing higher levels of people thinking that John's experiencing a physical or mental illness, and more people thinking as well that John's experiencing a chronic illness. So again, the people who are working and living in the space all the time are holding less stigma, significantly less stigma than the general public from a national level. So on the next slide, we're looking at social distancing, and again, we're seeing that people hold much less stigma than others. So, Tara, if you want to go to the social distancing slide, we're looking at like most people are willing actually to move next door to John, to have him as a personal friend. The marriage number is still relatively low, but that was only 20% in the general public. So we're still seeing a pretty significant increase of looking at having somebody with a substance use disorder, an active substance use disorder, marry into the family. So there's something about being, this is not surprising to me, right? But there's something about being in the space that really does, the proximity, the learning, the knowledge, the exposure does really decrease stigma. And a significant increase in people were reported a strong willingness to have a group home, in their neighborhood, which is something that's really encouraging to see. On that next slide about the workplace, workplace is something that we talk about a lot right now. We still see, 2/3 of people are willing to have them as a coworker, but some of the proximity stuff, like kind of the closer that we got, hiring them, having them as a supervisor, working closely with, lower numbers than we would love, but still higher, still better than the national average. On the next slide, we're seeing very similarly that the traditional prejudice slide actually tracks really closely with the national data. The last couple here the last three here on the Waukesha County data, the next slide on structural stigma, we have strong support for broadening access to treatment, both through insurer and employer coverage of treatment, Everybody supported healthcare coverage for addiction treatment. We're looking at that. We want healthcare providers to care for people with opioid use disorder or substance use disorder, like anybody else with a chronic illness. And nearly everybody who responded believes that people with OUD should be directed to treatment instead of incarceration for drug-related nonviolent crimes. So exceptionally strong support in this group for supports to really help people with a substance use disorder. So to really break down structural stigma, there's a huge level of support. So for those of you who are in advocacy, this is a really important thing. On the next slide, specifically around medications for opioid use disorder, these numbers are also excellent, right? Almost everybody agreeing that it should be easily accessible, that it's an effective treatment. 92% of people would be willing to have an MOUD clinic in their neighborhood. This number nationally is right around 50%. And only 6% of respondents feeling like MOUD just substituted one drug for another, and that hovers almost at 50% nationally. So again, really, really encouraging stats here. And then lastly, on that the highlights on the harm reduction piece, we're seeing that 2 out of 3 people believe that there should be a safe injection site in the community. 95% of people said they know how to obtain naloxone, and 83% saying that they know how to administer it. And most respondents felt like Waukesha County is moving in the right direction as far as treatment availability, and people know where to find quality treatment for opioid use disorder. I mean, I know y'all don't have there's a lot of ways to compare this data, but having looked at a lot of communities across the country, it's really encouraging that this task force has such an intimate and aware knowledge of these pieces, right? Because this is not numbers that we typically see. So kudos to y'all for the work that you're doing. I just wanted to tie in quickly to the harm reduction piece, which is that, I know this is a very passionate topic right now. When you look at some of these principles, humanism and individualism, autonomy, pragmatism, this requires that we trust people with a substance use disorder. So when we're talking about trustworthiness, when we're talking about, do we think that somebody with a substance use disorder is trustworthy? We're seeing that number in this particular survey we did was 58%. So we're seeing that 58% of respondents felt that John was trustworthy or competent. But you have to really lean into those beliefs to really do harm reduction work well, right? Because if you don't, right, then we don't believe that he should have autonomy. We don't believe, in the individualism component as strongly as we probably should. So really looking at this piece as we think about it, to really thinking that, as there is still a lot of stigma, I think more broadly around the harm reduction ideas, that a lot of this is actually going to go back to really addressing ideas of competence and trustworthiness and somebody's ability to make their own decisions. So I'm just going to take a couple slides to talk real quickly about how we've operationalized this, just so that you guys have an understanding of the different ways to leverage this data like this. An example of what we did is in our national index, and we looked at healthcare professionals, right? And we noticed that healthcare professionals believe that substance use disorder is not a chronic disease, roughly the same way that the general public is. We would think that this would be different given levels of education and exposure, but that's not apparently the case, right? We're seeing a higher level of healthcare professionals who are unwilling to move next door to somebody with substance use disorder, higher than the general public. Most people would be less willing to have people with a substance use disorder as a close friend. And actually a higher percentage of healthcare professionals endorse the harmful belief that MOUD is simply substituting one drug for another. Again, this is not Waukesha County specific, this is the national index, but this led us to, in conjunction with the next slide, which is saying, that if you take a look at this, you see this manifest clinically. We see that people cannot get the necessary medical care to receive liver transplants, to do valve repair surgery, reduced access to primary care and the justice system involvement and whatnot for pregnant patients, et cetera. This is how addiction stigma manifests, right? So we take the slide before this, we take this slide and we take the next slide, which talks about how actually stigmatizing language actually leads to decreased treatment of pain, and how healthcare professional attitudes cycle, right? Medical students aren't intrinsically more stigmatizing of people with a substance use disorder than the general population. But there's something that happened, right? as people exist in the medical care space for longer and longer, which seemingly increases stigma to a certain extent. What is it? How does it work, right? So, at Shatterproof, what we've done pulling this apart is we have a few different interventions in the healthcare space to try to pull apart what's happening here and then to try to address it. So we actually have some, there's a new article that literally I got in my inbox this morning, which I'm really excited to share with all of you guys, that really looks at some of this. But, this is a really good example of how, like, if you're thinking, okay, but I work specifically in prevention, or I really work in the criminal justice system, this is the kind of work that can be done to kind of take a look at attitudes, to marry it with data, and then to create interventions to really look towards reducing addiction stigma. And again, that is also what the action team is here to help with and to do and to support. So obviously I'm here, I'm not going anywhere, and happy to keep helping with this. So two slides, I guess, before we go to Q&A. The first one is this next slide, where I wanted to just talk about, sometimes we're not in a place to really do it all ourselves, right? Like, maybe we don't have organizational support. Maybe we don't actually work in the substance use field, right? And we work somewhere else, or you're not doing this all day, every day. So what does it look like to actually do some of this work individually, some of the individual actions that we can take? One of those things is using person-first and recovery-centered language. So again, person with a substance use disorder is one of those really good examples. Or, not using words like a dirty test, right? Not using words like addict. What that does is it really changes the paradigm in our brains. And this has actually been demonstrably impactful in the healthcare space, with people who read a vignette saying substance abuser versus somebody with a substance use disorder, with people, and these are mental health and substance use professionals. People who read the term substance use disorder as opposed to abuser were less likely to recommend punitive action and less likely to believe that people with a substance use disorder were personally responsible. So language matters, right? It just does. And for those of you wondering, well, how do I step in? How do I correct? What do I do? I mean, sometimes it's written, sometimes it's an opportunity to step in and say, like, hey, actually, we use this language, or this is why we should use this language. Sometimes you can't do it in real time and you have to circle back to it. There's lots of different methods to really look at that language change. Secondarily, we're looking at eliminating barriers, those structural barriers. Again, those of you in the advocacy space, what does it look like to do the work? Sharing stories and sympathetic narratives is important. So sharing stories of treatment and recovery, sharing stories of hope, like we saw again in the video to start, but also sharing real stories. Like, people with a substance use disorder, regardless of where they're at in their journey, are real people, right? What does it look like to share, to humanize, to contextualize, and then also to define people beyond substance use? A person with a substance use disorder is also somebody's child, somebody's partner, somebody's coworker, somebody just in the community, right? So humanizing. And then for those of us who can, again, incorporating the stigma awareness and reduction trainings is important. And then on the next slide, before we kind of go into some of the Q&A, I wanted to note that for those of you who are thinking about this, right, we're looking at we're still looking at tailored messaging. So again, who are you talking to, right? If you're talking about in the prevention space, like primary prevention, it's a different message than if you're talking to treatment professionals. So what does it look like? Who are we talking to? Are we talking to people who live in I don't know, in New Berlin versus Oconomowoc? These are two different cities, right? Two different groups of people. Are we talking to people who are in treatment versus that? So what does tailored messaging look like? Looking at contact-based strategies and person-first education we've talked about. Evaluation is obviously really important so that we can establish what works and what doesn't. And then the idea of collective impact. And this group here in Waukesha County is a great example of using a collective impact model where everybody has kind of aligned on common goals. So everybody's organizations and everybody's work has their own goals, their own agenda, their own things that they're doing. The idea behind collective impact is that in this room, we have set aside those individual things and we have coalesced around a collective agenda, a collective goal. So again, for those of you who are sitting here thinking, oh my God, this is a ton of information, the slides will be out there, and I'm on the action team, so we'll be happy to support however needed. I did want to then note that we have a few minutes set aside here for Q&A. I know we got into my part of about 5 minutes later than we thought we were going to, but I did want to talk about a little bit, just to, again, touch on very quickly there's a lot of passion in this group. Some of the questions that we had submitted really look at that harm reduction space. So why don't we want, why don't people want to be more welcoming and more tolerant? You know, why do we, you know, how can we build understanding and really moving away from intolerance and disdain and fear, really moving towards, you know, this kind of empathy and care, and why some of the tools specifically are more stigmatized, you know, than others, right? Like I started doing this work a decade ago in harm reduction. When I look back at 2013, we've come way, way farther than I like mentally thought at the time as pertains to acceptance of like needle exchange programs. But at the time, it didn't really feel that way, right? So I think that a lot of that has to do with, and I'm not going to go too far into this because it's not really the point, but there's a lot of morality that's associated with substance use. And when you start to put moral feelings around different types of drugs, around different pathways, right? When you moralize the drug itself, it's complicated when some drugs are scarier, quote unquote, than others. We know that people hold higher levels of stigma towards people who use methamphetamine than people who use alcohol. We know this is demonstrably true, right? So when we look at some of these levels of stigma, one of the things that speaks to me very clearly is that if we sit in that moralizing space, as opposed to really stepping back and not thinking about the drug, but really thinking more about the person, then that's a lot of where those contact-based strategies, that story sharing. Again, John, the story that was shared earlier, Megan, like that is a classic example. It's an excellent example of saying, this is a person who experienced all of these things, and look at where we are. As stories of hope, but not minimizing and not ignoring the difficulties, talking about them and talking about the tools. Again, communicable disease is a great example of like why syringe exchanges are important, but it doesn't necessarily get to the humanizing part, right? So really thinking about the humanizing and those kind of contact-based strategies is a critical space. So managed, Terry, to get through this right on the 30, but we did not do Q&A. So if you want to, happy to do some of that now.
Yeah, there's a lot that you delivered.
I know.
My mind is swirling. I have questions.
I
but
know. My mind is swirling too.
Yeah, thank you so much, Rachel. So we're gonna open it up. I'm gonna ask if you can use the hand raise feature. That would be really helpful. If you can't find it, just unmute and we'll get you in the queue. But and or use the chat if you would like to submit a question via chat. And I'm just looking at chat here. Yeah, Nicole Matson says, this was wonderful. Thank you for your presentation. It was really fascinating. Our numbers as a team were interesting to me. I wonder what our numbers in Waukesha County community is. That would be my comment, not necessarily a question. So
same here.
Questions from our Heroin Task Force members. Giving you guys a second to take a breath here.
Y'all can also email at any given point. This is an ongoing conversation. So no pressure to kind of come up with something on the spot.
Yeah, and remember, we have a stigma reduction action team. This came a year ago. That surfaced to the top as a concern from this group. So Nicole Bry, you can send an email to her. She can get it to the right team. We can put Jake, maybe, and you and Colleen might add some things. So I've got Stephanie Engel and then one in the chat. So Stephanie Engel, you go first.
Thank you. So this is, I guess, more of an inquiry. I attended the harm reduction conference, and there was this speaker who really spoke to what you were talking about the prevalence of stigma in the healthcare field. And he had talked about being a person in recovery. I think he was a physician, and he had really struggled with substance use. And he had put forth some research that was very interesting because it really actually indicated that there's a pretty high prevalence of substance use in the healthcare community. And so I'm actually curious if you are aware of that research.
I'm pretty sure you're talking about Sean Fogler, who I adore and is a good friend of mine. So yes, to put it quickly, yes, I'm aware of Sean's work, and I'm actually happy to happy to send on some of the stuff that he's worked on, but there's definitely a conversation to be had about substance use within the healthcare field, the resultant stigmas that exist, and in that workplace stuff. I mean, that is a lot. So I'm happy to send that on, and Terry, I'll probably just send it to you directly. And
Perfect.
then you can send it out to the group. And Stephanie, if you're actually interested in connecting with Sean, I can directly make that connection for you.
That would be amazing. I was looking for his research and I could not find it anywhere.
Yeah,
So
I've
thank
got
you
it.
so
I'll
much.
send it along, but I can also make that connection.
Thank you.
Perfect. Great question, Stephanie. And then we also had one in the chat that she has already answered, that Rachel's already answered. There were 36 of our members that submitted the survey. So any other questions we'd like to, we just get Rachel back in here. Any other questions that we would like Rachel to address at this point? Jim says the number of healthcare providers who do not view SUDs as a chronic brain disease is alarming. I thought the same thing. They should be teaching this in medical school, right? So, all right. We have just about a 5-minute break, and I actually think I'm going to ask you to make it a 3-minute break. I'm not even going to put a timer on. I'm going to just ask you to just maybe turn off your video for a second, step away from the computer for a minute so we can come back into small groups and unpack this information. I'm begging you to stay. I really am begging you to stay. I know a lot of people pop off after a presenter, but we have some tremendous questions that we teed up in your agenda. You can see them. We have small group facilitators ready to take notes. This is such an important topic for our community. We really are urging you to stay. So I'm just going to give you a couple of minutes. It's 3:36 on my clock. I'm going to say 3:39. That gives you 3 minutes to just step away from the computer for a minute. All right. Thank you. All right. Welcome back from our short little break. Again, Rachel Cooper, thank you so much for this information. We were chatting during the break about all the ideas that are swirling in our head. So at this point, we're going to give you an opportunity to unpack these ideas that might be swirling in your head with your partners. So I'm going to share my screen here. You guys can see okay? You are automatically going to be put into a breakout room. We'll be in a breakout room for about 20 minutes. We have designated scribe facilitators who will share their screen and take notes. They might do a little bit of light facilitation, speed introductions real quick. If you know everyone in the room, keep moving. We have 5 questions to ponder as a group, and your facilitator will help you through those questions, but it might be helpful to select a timekeeper. So you have 3 or 4 minutes per question, and then highlight a couple of things that stand out to you. And we're going to ask a reporter to share out the information with the full group. I don't want you to read your slides, so just think about a couple of pieces of information that you would like to share. And all of this, of course, will be distributed to the full group. I just wanted you to also please thank your small group facilitator. I continue to tap on pretty much the same groups, so I want you to please thank them for helping us out. So at this point, you will automatically be put into a breakout room. I think, Rachel, we are good to go, and enjoy your 20 minutes. All right, so welcome back, and we are going to just I'll share my screen, and we're going to ask each team to just share out a couple of the highlights. Please don't read the screen.
Everyone
we don't have
a good conversation.
Oh, can you hear me okay?
Great.
Okay.
Good to hear.
Great. Okay. Fantastic. All right. So Nicole Kelly, I think we're going to start with your team, whoever is your reporter.
It's me. No one volunteered, surprisingly.
Oh, no, you have to volunteer someone.
Nah. It was a good conversation. I think there'll probably be a popular answer, but we would really like to allocate some resources towards surveying the Waukesha accounting community and utilizing that data to kind of inform our actions moving forward. We also talked a lot about identifying our different audiences and what education we might use for them, or what messaging would be the most useful, and holding each other accountable and maybe offering some type of training on how to do that without calling someone out. If there are better ways to really call them in and provide them education without making anyone feel uncomfortable.
Great. Thank you. Thanks so much, Nicole. Thank you for you and your team. Gabby is also with Shatterproof. So nice to have you here today. Thanks for facilitating one of our small rooms.
Yeah, really excited to be here. So yeah, we were just so into the conversation, I didn't volunteer anyone. So yeah, I think one of the main things was really this focus on continuing the conversation, making sure this isn't, just a one and done presentation. We had some, desire around, like, people were surprised at the statistics that we were seeing, especially when there are some gaps in being able to connect people to services. So there was a desire for education around that, and sharing that more broadly. And also creating, again, some type of tool to further education. And I will say that might be a common theme. Shatterproof does have a few tools, so I'm sure Rachel can send some things over. We have a few guides we've created, so we're not, recreating the wheel, and there's some things there that we can share. But yeah, really great conversation.
Great. Thank you so much. And I see working on story collection, and I know that's something Nicole Kelly is our PIO for HHS. And so I know she is eager to do that. My team, I think Anne Marie, you're going to be our spokesperson.
Yes. So some of the things we talked about were, again, continuing with more surveys to kind of get the idea of, where the stigma lies in our county and whatnot. And then we also talked about the school district in particular, developing a training for school boards and school staff on the Narcan. Availability in the schools would be hugely beneficial.
Great. Thank you so much, Anne Marie. Yeah, our conversation was very similar to the other two at this point as well. Breakout room 4. I don't know who the scribe was there. Took lots of great notes, though.
That would have been me.
All right, Jamie.
Similar to the first and second group, I also didn't volunteer anybody to do anything. So I'll go ahead and report out. We also thought that it would be great to have data for our community and to be able to see, where are some areas that we can strengthen and where we're doing well. We also talked about how the workplace seems to be a really sticky spot for people who have a substance use disorder. And so maybe looking at different professions or how to incorporate this in those different areas, having that targeted messaging and education.
Great, Jamie. Thank you. Thanks so much for the conversation. And breakout room 5.
That was us. So
thanks, Francis.
We talked about the things that stood out to us was remembering and reminding people to use person first language. We also talked a lot about how the different levels of stigma really impact the strategies that we take to get rid of some of the stigma around substance use disorders. When we're talking about our implications for the work of the Heroin Task Force, we really thought we need some procedures of how we use this data and information and things that we always do before we embark on a project. So we always collect data, we always do research and embedding stuff like that. When we flip to question 3, things that we felt were doable were sharing our stories and working with collective impact. So something we felt we could do right now was reach beyond typical partners and reach into some atypical partners, especially when it comes to employment, because piggybacking off Jamie's group, that really stuck for us as well. People like the Workforce Development Board and certain employers are great first steps. And then things that we want to work up to as a Heroin Task Force is working on advocacy and policy around workforce and substance use disorder. So creating policies that would prohibit, thanks for typing, Carrie, that would prohibit people from being discriminated against if they had a substance use disorder and they wanted to focus on their recovery and also be employed. So really
good.
person.
Appreciate it. So great conversation. And just as a side note, where we are going to be meeting with, we're reaching out to the Workforce Development Board, Business Alliance, and the Center for Growth. And we will be meeting with them to begin the conversation with our business community, and hoping that we can do something next year with them for sure. So that's very consistent. That's great. And Julie,
Successful.
yeah.
We voluntold Kirk. So
All right, Kirk.
take it away, Kirk.
I was happy to do it. So let's see. A lot of the same ideas resonated with our group. The levels of stigma within the healthcare workforce was surprising, and that really drove our conversation around actions that we could take. So, one is that survey instrument, making that available to healthcare organizations or systems for their leadership to have a better understanding of the levels of stigma or bias within the workforce. And then maybe kind of upstream from that is doing creating some sort of a stigma reduction training or using one that's available to target that workforce if it's identified that there's a higher level of stigma there than what you'd want. And then also targeting academic programs for healthcare workforce students, right? Whether that's nursing programs, medical programs, et cetera. Looking at what they have within their curriculum. Does it address this, or is this a potential addition so that by the time they get to the workforce, they have heightened awareness around stigma and bias?
Great, Kirk. Thank you. Outstanding. All right. And Felicia, your team.
It's going to be me reporting. So we also shared a lot of the same conversations. We talked a lot about stigma and stigma reduction and the unconscious bias. One of the participants really used the example of paper cuts are small, but they really hurt. And it's so true. And making data-driven decisions. And our main point that we really liked and we thought was really important for us to carry through would be education. The data shows that we're receptive for education right now and understanding and the reduction of that stigma. And then also moving forward, looking at the community environmental scanning and using the tool and the anti-stigma toolkit to really see where our community is at and where we can start.
Awesome. Awesome. Thank you so much. Appreciate it. And I think I'm going to go to slide 9, and then Lucy will come to you. We'll finish with you. So we'll do Mary at 9, and then we'll come back to Lucy.
Yeah, so I didn't volunteer anybody either, so you get me. Echoing a lot of what the other group said about the statistics, the data, particularly from this group, that 67% people were open to a safe injection site, and how that's not necessarily how we perceive things to be in the community. So that kind of data was really interesting, and more data like that I think would be helpful. One of the other things that we talked about that I think would be interesting for us to do for the community gatherings is to be intentional about some of this work, even in our community gatherings, to give people time to maybe reflect back on a situation where they maybe could have used better language or were exposed to someone using language that they found to be offensive and speaking up. And I'm not describing this very well, but I think just having those opportunities for us to do that reflection in a safe place like the community gatherings are, or should be at least.
Absolutely. Absolutely. Thank you so much. And I'm going to stop sharing. Lucy couldn't access our slides because of their system. So Lucy downloaded it and she has it on a PowerPoint.
All right, hopefully everyone can see our slides for that. And our conversation too, a lot of it came up to relation to, I think the first question too was the stigma reduction for students. Students kept coming up as like a theme too for our group. And then the other thing too, I really wanted to highlight here is the time and impact of education. That also came back, one of the group members shared their story of learning about drugs through the DARE program, and also too like how that has, you know, continued with them throughout their life. So something I think that we could also move forward is continuing the, again, our education and being a conversation starter for these, but also to realizing, will this information be relevant in the next 6 months, 12 months, years, even years down the road? Because again, education does have a powerful tool. And then for our other questions, we were talking about, you know, continuing to use our fact sheets, being able to, we have a lot of great community partners here at the Heroin Task Force. So continuing to utilize those resources, continuing to utilize shatterproof surveys that they have, their fact sheets, tip sheets, and hopefully we would love to see like a centralized database in the next 12 to 18 months for the Heroin Task Force. So it's a one-stop shop where all of this information can be. Would even be nice, we were talking about, as especially on the term of stigma reduction, how it's not like, you know, like just a one word, or it's not just something that you'd see on a billboard or a bus. These are conversations, they have emotions, they have, you know, even to trauma sometimes attached to it. So again, being able to have small group conversations, one-on-one conversations, and having data that is available.
Great, Lucy, thank you. Wow, a lot, right? This was a great conversation. Just to share kind of what's next, we're going to take this information, kind of cluster the key themes. It's going to go to our stigma reduction action team, and then also conversations with our steering committee to work on next steps. But there's some concrete action that we can take. There's a lot of consistent themes that have surfaced, so this is wonderful. This was when Rachel and I were setting this meeting up, we wanted to spend time on the work of the Heroin Task Force, but we also wanted and recognized that this is also an individual journey as well as our task force journey. And so what I'm going to invite you, just one second here, let me share my screen. I'm going to invite you to take a minute individually to think about what your personal next steps in this journey might be. When I took the survey, there were some questions that caught me off guard, and it caused me to do some internal reflection. So I'd like you to just take out a piece of paper. You don't need to share it with anybody, but just to take a minute. We're going to take 2 minutes just to think about what our next steps might be. So we'll give you a couple of minutes here. It's 4:16, maybe 4:18. All right, I'm going to welcome you back in here. I really appreciate the thoughtfulness and the conversations that we had today. I am going to, continue apparently playing my music. I'm going to, at this point, ask our action teams just for a quick update as to what is happening in their world. And again, Nicole, Bry, I'm going to ask you just to pop your email address in the chat. And if anyone is interested in joining one of the teams as you are listening, she can direct you to the right people. So since we've been talking about stigma and stigma reduction and awareness, let's start. Jake, Colleen, I'm going to turn to you for just a couple of minute update on your progress in your action team.
Colleen, are you there? We talked earlier. Oh,
yeah, I'm here.
Did you want to give the update on the stigma reduction team?
I can, and then you can correct
I'll
it if I miss something.
Perfect.
So we've been busy this last quarter, focusing on stigma reduction by researching and discussing language and its impact on stigma. We are preparing for today's meeting, the community event that featured Rachel Cooper. We reviewed and edited a code of ethics for the Heroin Task Force for presenters that's been submitted. We're waiting to finalize that. And we're continuing to work on opening conversations with community partners. And next week, we're meeting with local law enforcement to see how we can help support and any efforts that we can do with the police department as far as stigma reduction. Did I forget anything, Jake?
Perfect and concise. That was great.
Great.
That's
Thanks.
nothing.
Thank you guys. And with all this great information, I know there's a lot more ahead of you. So thanks for all that you're doing. And Bree Lopez, are you still on in the a meeting? Do you mind giving us a quick update of the CHIP substance use action team?
Sure, absolutely. So, yeah, our group has been meeting real consistently. We kind of did a little bit of a regroup and had a really productive meeting this last month. So we were able to identify what our end results will be. So I'll read you both of those. So the first one was people who use or are in recovery for opiate use in Waukesha County will have access to life-saving interventions. And just a little bit more on that one, we really as a group talked a lot about what life-saving interventions means and kind of wanted to make sure that we recognize that was a broad term. It wasn't just looking at Narcan, for example. One of the things we really want to focus on with that end result is like social connectedness and looking at peer support. And then our other end result was Waukesha County residents who use opiates have access to stable housing. And developed a few indicators to support both of those. So we'll be digging more into that, what data drives those decisions, where we're going with those end results. So our next steps, we are going to have our first in-person meeting later this month. So we're really excited about that. One of our tri-chairs works out of county, so it's been real difficult for us to do in-person meetings, but we made a goal to just at least do this next one. And we will be working on our root cause analysis. And we've got Terry and Francis kind of on the hook to help us with that. As tri-chairs, we really wanted to be present and participate in that. So they're going to help to facilitate that discussion so the tri-chairs can be more participants.
Great, Bree, thank you. And we are looking forward to doing that with you. I'm going to turn to Jim. I saw that you're here, Jim Hishma or Susie Austin. If you can give us a quick highlight on the support recovery team. Oh, and they may not be here. I'm meeting actually with that team this Friday. They have just regrouped as well. And I know that they were working on that, the vigil, they did that, but they're also they've brainstormed some different ideas and more to come. They're going to be able to give you more information at our next meeting. And then the last but not least, Felicia and Francis, the data and metrics and measurements team.
Yeah, so we've been busy meeting with all the other action teams, me and Francis, looking at ways that we can support the other action teams. We've also, we have one more action team still to meet with. Don't worry, we haven't forgotten about you. We have a upcoming meeting with WellPath and Vital Strategies, which both happen to be on the same day, just to talk about more ways that we can gather data and partner together. So we have been busy as well, and we're also working on a data survey. So stay tuned for that.
And that's like a data literacy survey, right?
Yes, that is correct.
Fantastic. Great, Felicia. Thank you so much. I am going to just ask, John just started us off, quick plug. He put into the chat. Is there any other agency who would like to share a quick partner announcement or something that's coming up that you want to make sure that the partners know about? Here's your chance.
Terry, I will. It's Jody Ebinger Bentley.
Thank you, Jody.
Our peers, for peers groups which promote sober living and abstinence from drugs and alcohol at our 3 high schools in Waukesha, they are doing a Be the Majority awareness campaign at an upcoming Waukesha South versus Waukesha West football game on Friday, September 29th at Waukesha South. high school. So it'll be a regular football game, but our peer helpers that are a part of that club in the high school will be promoting just, hey, the majority of us do not use drugs and alcohol, and come be a part of us. We'll have lots of giveaways for students. They love to throw the t-shirts out into the stands during halftime. And then we'll also be having a smaller parent resource fair. If your organization would like to be a part, and again, this is more of a prevention event or awareness event, but if your organization would like to be a part of that resource fair, you should reach out to me, or just maybe put your name in the chat and I'll reach out to you. But I already do have ARC and county and Elevate coming to be a part of that.
Great.
We would love to have you guys. The resource fair starts at 6:30. The game starts at 7.
Thank you. And Jody, if you want to just pop your email address in the chat, that would be great.
Sure. Thank you.
Thank you. Thanks so much. Anybody else?
I do. I'm
Great,
sorry.
Allison.
When
Thank
you
you.
announced it, I was looking on the Shatterproof website. So I'm from Bethany Recovery Center, and this is really short notice. So if anybody knows of motorcycle people, or if you're a Harley rider, or we're having a Harley ride this Saturday to raise money for our center. So we start at Harley here in Oconomowoc, and there's a whole route that they have planned, and raffles and a band. So yeah.
Thanks so much. And Allison, if you want to pop your information in the chat so folks can connect with you, that would be great.
You bet. Thanks.
Thanks for sharing. And anybody else? This is our chance. Thank you so much for the information. All right. I think Larry, you have joined us, so I think you are taking the last slide, if I'm correct.
Well, thank you, Terry. I want to thank everyone for coming today. I believe it was exactly a year ago when we had a community partners meeting that stigma and stigma reduction was identified as an area that the Heroin Task Force should work on. So we're very excited to have this first community partners meeting, and I want to thank Rachel for speaking and leading the discussion. But this is step one. We'll be following up on what happened today, and I hope most of you can join us on our last community partners meeting of the year on December 5th, because tentatively, I believe we're going to ask you to talk to one of the 4 action teams about their plans or goals for 2024. And we'd love to have your input on what we should be focusing on, both as action teams as well as topics for the community partners. So I believe we had 52 people participating at the high mark. I think we had 37 still around for the small group discussions, because we can't have a good task force and coalition without all of you that are willing to participate. So thank you very much. I'm sorry if I'm in a weird background because I'm in a county room with bad lighting. So Terry, you have 1 minute left.
And I think that is it. As Larry mentioned, December 5th is our next meeting. We're still putting the agenda together, but we are going to spend some time focusing on the work of our action teams. We also are going to spend a little bit of reflection time on 23 and of course, planning for 24. And there will always be more to come, but we have quite a bit of information now from today that I think will help our stigma team as well as the sport recovery team with some new ideas. So if there's not anything else anybody else wants to share, I want to thank you all for hanging in here. We appreciate you. We appreciate all the work that you do, and glad to have you with us tonight. Thank you so much.